All right, Peter, we are live and we are back again. Back again. I'm here with the scientist.
Hello.
Our scientist.
Hello, everyone.
Our scientist is back in the hot seat with us. We're dubbing today Education Day. So, Peter, welcome back to the show.
Thank you. Thank you. Happy to be back.
Yes.
Happy to be talking science again.
Yes, yes. I know it's one of your favorite topics. It's like me drinking coffee, you talking about science.
Yes.
So last week, I think it was, we began a discussion on, I guess, adjuvant therapy,
Well,
and
breast
so
cancer basics in the
y-
con-
yes,
yeah.
we want to continue that conversation, maybe broaden it a little bit. But before we get started, can you explain what adjuvant mean? Again, Peter, we're talking to that woman who got that packet, or that man who got that packet from the doctor, and it says adjuvant therapy needed. And what does that mean? It's,
Yeah.
we don't want to go to Google. We want to ask you.
Yeah. Well, we talked about this a little bit last week in terms of breast cancer, but really this can be applied not only to breast cancer, but to a lot of different types of solid tumors, right?
Mhm.
You have generally speaking, you'll go for surgery to remove the tumor. Maybe they'll remove some lymph nodes, okay? But the goal is to remove the tumor and cure you of your cancer. And so the purpose of adjuvant therapy, what we call adjuvant treatment, and this can be either chemotherapy or in the case of breast cancer, it can be endocrine therapy. But the purpose of that is to eradicate any what we call micrometastatic disease, any cells that might have been left behind. I mean, your surgery might have gone fine. The surgical margins may be very clear under a microscope, no cancer cells. Similarly, the lymph nodes may be completely clear of any cancer, but there may have been cells that may have been missed, that may have escaped, and any cell that is left behind is one that can grow back later. So the purpose of adjuvant therapy is after your surgery. It's a therapy that's done after your surgery,
Mhm.
and the purpose is to eradicate any cells that cancer cells that might have been left behind, so that they don't grow back later and cause a recurrence. So,
Okay. All right. So that makes sense. But I'm thinking about a recent patient that I know, right, who had a tumor 5 centimeters, and some one node involvement.
Mhm.
She had the surgery, refusing both chemo and radiotherapy.
When it
Um,
was recommended. That was
it was
recommended.
recommended. It was recommended, and definitely no endocrine therapy either. No tamoxifen or anything like that. This is a young woman under 50. She wants to try to go natural with plant-based diet.
Mhm.
In your experience, or in your thoughts of what you're seeing out there, what is the risk with that? I mean, the doctor on Monday said, "Oh, you're 5 times more likely to have a recurrence if you don't do one of these therapies."
Yeah. Well, there's a good reason that her physician can make that kind of statement,
Mhm.
because generally speaking, your risk for recurrence, your risk that you're not going to be cured by just surgery alone, is generally based on historical data. So
Mhm.
what we're going to talk about today is in terms of they base it on what's called clinical risk. Clinical factors that determine your risk for recurrence.
Mhm.
Um, and again, we're gonna get into this a little bit later, but really, it comes down to a personal decision, right? This is a
Yes.
decision.
Yeah.
There's risks and benefits to everything. This is a decision that you have to be comfortable with your oncologist or your surgeon. But generally, the surgeon is speaking from experience that based on the clinical factors of your tumor, you're going to have this, this risk for recurrence. And those are things by determining, it's called TNM staging. Generally, this has been used for solid tumors for many decades. It's T is tumor size. So
Mhm.
how big is the tumor? It's usually in centimeters. So obviously, the bigger the tumor, the higher your risk for it. It's a bigger mass, more chance that cells have escaped, right? The bigger the tumor, that's the more likelihood, greater likelihood of recurrence. The smaller, there's less likelihood of recurrence. Second thing, N, nodal involvement. Has the primary tumor cancer spread to the local lymph nodes? So if they do a surgical excision of your tumor, they'll sometimes take what's called a sentinel lymph node, lymph node that's in the close proximity to the tumor, to see if that would be the place that it would go first, to the closest lymph node. So do you have lymph node involvement? Usually there's a certain, you had, they'll give you a number like, one node was positive or two nodes were positive or more. So that's obviously the more nodes you have involved, if you do have lymph node involvement, or if you don't have any lymph node involvement, that's lower chance of recurrence. If the lymph nodes are not involved, higher chance of recurrence, the more lymph nodes that are positive. Okay. Third thing, M, metastasis. Has the tumor spread beyond the primary site to other organs? And that's something that would probably be determined by imaging or whatever. But yeah, so T and M staging. So based on all of and there's actually another thing which is sometimes done this is something that's done by a pathologist, or it's like a histological examination of your tumor. It's called Ki-67, Ki-67. And sometimes we'll do that type of testing. What that is, it's a measure of the overall rate of proliferation. How fast are the tumor cells dividing? Sometimes called like how aggressive is it likely to be? So that's another thing that they could measure. But based upon all of these factors, they can give you an idea based upon historical, for people that have your specific type of tumor with that specific TNM stage or Ki-67 status, what is your likelihood of recurrence? So, there could be a 95% chance that you're going to recur. And based upon that, you would make the decision, well, based upon that particular characteristics, chemotherapy, adjuvant chemotherapy to eradicate that residual disease is going to very likely improve your chances for surviving without a recurrence.
Gotcha.
So
wow.
That's the basics of like clinical risk. Now, as I said, clinical risk has been around for a long time. We know that these factors impact the degree to which your cancer can spread or not. But there's a lot of new technologies, and that's what we kind of want to get to.
Yeah.
These clinical risk factors are not perfect. It's an estimate based upon population analyses that have been done over many years, but they're not perfect. And more importantly, sometimes people are kind of in the middle or on the borderline. And I'll give you the example later of stage 2 colorectal cancer. It's a very big question mark if you have certain clinical factors that is chemotherapy going to be beneficial to you or not. So
yes, and I think with chemotherapy, because I've heard this said by you and by others, sometimes the chemotherapy is the damage that it does is sometimes almost worse than the cancer. And so I know no one really wants to do it unless they have to. I heard at one of our conferences someone said in the next 10 years there may not be chemotherapy. There might be something else, and I'm praying for that day because of all the negativity that's around chemotherapy. And
I've heard it said too is like and by one of our faculty members, it's like anytime you cannot give chemotherapy, that's a great thing.
Yeah.
Based upon that clinical risk, you have to decide whether or not the benefit of chemotherapy, giving something like chemotherapy, outweighs the risks that it could impart. So, I mean, if you have like less than and I'm just going to use my wife's testing example. She had like chemotherapy was going to give her less than a 1% benefit. in terms of her survival-free of recurrence. So, I mean, in that
Yes.
case, you're clearly dealing with a situation that giving the therapy is going to do more is going to do more harm than
Yes.
any benefit that it's going to offer
You
you.
know, that's a good example, Peter. And I also remember too, even with the radiotherapy, um, which I didn't, you learn these things when you're going through it. They can give you 3 weeks or 15 treatments or 20 or 25, or because when I was in the radiotherapy, there were people, going on, 30 days, so they
Yeah.
told me, hey, you need 15 days, but this other person may need 28 days, or this other person may need 30 days. So even with that too, even with the radiotherapy, it varies depending on these
Individualized. Yeah.
T and M results, correct?
Right. Right.
Yeah, yeah. When is genetic testing indicated?
Sure.
Because, and I want to ask you this before you answer that, Peter, because I've been hearing a lot about this genetic testing. So it's not an automatic when you have
No,
cancer. It's not an okay.
no, maybe someday it will be because maybe the technology will be that much more advanced. It'll be a lot cheaper,
Mhm.
and there'll be a lot more information that can be gained from that. But
Yeah.
right now, genetic testing, I'm talking about testing your DNA to look
Okay.
for specific cancer-causing genes. That is indicated sometimes when patients are very young for this particular cancer. Like, if you have a young breast cancer patient, that can sometimes set off an alarm. Hey, do you have any family history? Did your first degree relative die of breast cancer or a different type of cancer? So those might be indications where the red flag goes up. Hey, maybe we should do genetic testing in this patient to see if they have any genetic predisposition for cancer. And certainly in the case of breast cancers, that's a relevant information to have if because there are certain treatments that are useful for patients that have like a BRC, one of the breast cancer gene mutations. Another indication for breast cancer is if somebody doesn't have or doesn't know their family history, like Julia was adopted. She didn't know anything about her family history. So, that can have implications, obviously, for your daughter or your son.
Right.
So, and not only could it have an impact on your treatment, how they're going to treat your cancer, but, there are other there are other implications for your family members. Like maybe they would need to have advanced screening or additional screening for a specific type of cancer, like breast cancer, for example, if you have a breast cancer gene mutation.
Let me ask you something, Peter. If you get tested, right? You don't have cancer yet, but you get tested and it shows that you have these genes.
Mm-hmm.
Are they giving you medicine to help you, to go against it? Or, I mean,
Yeah, I don't think
t- t-
that's ever. I don't think that's genetic testing is currently indicated, or that you would act to do anything to prevent cancer based upon your genetic test results. But you may be more, maybe want to do more extensive screening, or I mean, this is something that you would have to, discuss with your doctor. And, when you do genetic testings, there's all kinds of implications and information that can be gotten from that testing.
yeah.
So you want to know what the implications would be if the results are one way or another.
Well, I'll just throw this out there. I mean, Angelina Jolie made big news when she did the genetic testing and came back BRCA positive, and she had a double mastectomy, and then she went back and had a hysterectomy because she said she wanted to be here for her kids.
Right.
So I guess
They're all connected. It's the breast cancer risk and ovarian cancer risk
yes,
with
yes.
BRCA patients.
So I guess it's up to you if you want to know, and if you do know, what you want to do about it. So yeah. Okay. All right. What other types of testing may be done?
Yeah, now see, this is where we get into the, kind of the newer technologies. And, I like to say this is not the same way that your grandfather's lung cancer was treated. I mean, because they had TNM staging back in the day as well. or it's not the same way your grandmother's breast cancer was treated. Now there's a lot of new technologies, and it's worth knowing a little bit about them. Now we have in breast cancer, certainly, but also for other cancer types, we have what's called genomic classifiers. And what that does is it essentially is a way of studying the tumor's genetics, not your genetics. So this is the genetics of your tumor. So basically what they're doing is they're taking your tumor sample and they're doing a genomic analysis on it. And what that can do is it tells you some of the biological characteristics of the tumor. And I know in breast cancer, there's certainly one that not only will determine your risk of recurrence over a 9-year period after surgery, right? But it can also tell you the degree to which chemotherapy will or will not benefit you. So this is pretty much over the last decade, people started doing this type of testing with genomic classifiers over the last decade. So this is something that they can kind of more fine-tune your risk in addition, on top of these clinical factors. Like you would already know a certain degree about your tumor just from the clinical characteristics we discussed. This is another level where you're studying the biology. You know that your tumor is, the genetic makeup of your tumor is associated with this much of a recurrence risk or this much of a benefit of chemotherapy. So that's a really valuable piece of information to have.
And that's one of the testing that we need more minority representation, right? Because the current genetic testing on the tumors right now,
certainly,
it's being used for all colors, right? Every group, but it wasn't tested, so its efficacy on minority representation is not 100%. But I did one of those testing, and I guess my score was low enough for me to be okay, because I think
both your and Julia's score was low, which indicated, as I said, less than a 1% benefit of therapy. So that's a position where there's no question you're not going to do it because the harm is greater than any potential benefit that you would get. And a lot of these clinical factors too have been studied in certainly they know a lot more from European populations.
Yes.
So certainly in terms of some of these genomic classifiers, there are many. There are at least a couple to choose from. Some of them are used more widely in Europe. And they need to be better tested in more diverse populations.
Yeah, Peter, you mentioned Europe, right? So I heard, Sarah sent me a video. It's on the tamoxifen story, right? How tamoxifen got started, and it was of course it was out of Europe as well. What was interesting to me was tamoxifen was first started out first as a contraceptive, as but then it was doing the opposite. It started out as a pill. But then it was doing the opposite of what it's supposed to do. And then it was reworked into this brilliant medicine that, they call it the wonder drug for breast cancer, right? Because it's so effective even for people who don't have breast cancer, who they recommend taking it if you're high risk. And you and I talk about this, Peter, in the off camera. We talk about, will there ever be a cure? I feel like we always get up to the edge. And yes, you said today on this show that is the way how your grandfather was treated for lung cancer, or your mother was treated for breast cancer, is really not the way we're treated today. But so I acknowledge that we're making good progress. I mean, would we want to see greater progress? Yes. But something you said to me off camera, you said that cancer may be one of those diseases that we manage, we never quite cure.
People always say, what's the, why can't they come up with a cure for cancer? And I mean, the short answer, the short one word answer is it's about diversity.
Yeah.
because there's so much diversity. I mean, that's a word we use a lot here. Totally. Uh, but there's so much diversity in cancer
Yeah.
that more and more we're realizing that there's really not going to be a one size fits all approach that's going to just stop every cancer dead in its tracks.
Hmm.
But we're understanding more about how each cancer type is different, and not only that, how it can be different in different people, different races, different sexes, different age groups.
Hmm.
um, so we're understanding a little bit more the nuance of why cancer is so diverse. So while there may not be a cure per se, we may be able to understand enough about any particular type of cancer that, like kind of like cardiovascular disease. Yeah, you have cancer, and it may have been spread, but we can keep it in, we know how to treat it. We can keep it in check so that you're much more likely to die of something else than die of your cancer. So that's I think the real promise that comes from that.
That's promising enough. I mean,
Yeah,
it's promising enough. It's blood pressure is kind of hard to cure. You know what I'm
yeah,
saying? And we take blood pressure meds, or whatever. So it's promising enough, especially once the cancer has spread. It's in the past that was an instant death sentence, and now we're seeing.
mhm,
We had a guest on the show who's living with stage 4,
yeah,
and living for the last 4 or 5 years,
true.
so that's encouraging. And one of our speakers 3 years ago was watching some of the old tapes, and he had said that he had a 17-year stage 4 cancer survivor that he's still treating. So that's promising enough. Now, Peter, before we go, I want to ask you this question. So we know that pancreatic cancer is one of those that are just very challenging, right? Is there a particular cancer that you would say, okay, if you get this cancer, it's still cancer, but there's so much out there for it that you have a good chance of pulling through?
Yeah. Well, actually, you know, uh, there is a specific time, and I learned about this many years ago. I'm not an expert on it, but there is a specific type of thyroid cancer where people can have metastases all over their body, but it's so slow growing, it's so indolent, as we say, that it's not going to, it's just a matter of, keeping the metastases in check with a little bit of treatment here and there. And, but they're living for, a long time with
Yeah.
metastatic disease. So, I know that there are certain cancer types that are more indolent than others,
Yeah.
but, um, you know, um, I'll probably think of another one later that's just like this. Here's something that we can manage, right?
Yeah. Well, as we end our show, Peter, can you leave the audience with something? I mean, I know it's tea talks, but as there may be a cancer patient, they may have someone in their family who's a cancer patient, and they're reading the hospital notes and the doctor's notes about adjuvant therapy. What can they ask their doctor, or how should they approach their doctor, or their family? Well, how do they make these decisions? I mean, what should they do, because it's very challenging for a lot of
Well,
people.
first of all, I think it's important to, I mean, as we kind of explained today, it's like
Mhm.
it's important to understand why you're doing the therapy. Like things like radiotherapy, a lot of people don't know. It's like you're not what you're doing with radiotherapy is not, you're not shrinking your tumor because you've already had your tumor removed. What you're doing is trying to eliminate that micrometastatic disease, that you're trying to reduce your chance for recurrence. So understand, first of all, why, just to understand why you're doing this. And also to understand what's my risk,
Mhm.
know that number. I mean, for some people, they have to have a very high likelihood that a treatment is going to be beneficial, like your friend who,
Yes.
before they're going to say, okay, yeah, you know what, that's a big risk reduction.
Mhm.
um, so understand, your risk with chemotherapy or whatever adjuvant therapy is this, and understand that if you do it, your risk will be this. So
Right.
have that number and be able to make that informed decision with your clinician. I mean, obviously, we want everybody to have that discussion with their clinician and understand all the risks and benefits of it. We like to, especially nowadays, have what we call shared decision making. So,
Mhm.
if you understand that, if you have an understanding of why you need any particular treatment, that's I think the most important thing. And to be able to then you're able to make that shared decision with your clinician.
Mhm. Well, Peter, I thank you so much again for your time. And I would say one of the high notes for today for me was this is not your grandfather's, cancer.
That's true.
It's not your grandfather's treatment. So there are things
Yeah,
to be
and
done to
there
find.
are there are other tools that we didn't really get into them today, but which you can read a little bit more. I put some links in the notes that you can link to in plain language, and kind of understand a little bit better about it. But yeah, I mean, more and more we're finding that we can individualize therapy for a larger number of patients, and that's going to lead to better outcomes because we understand their cancer better, we can treat it better, and
Mhm.
make more informed decisions about it.
That's right. All right. Well, thank you again, Mr. Peter. And until the next time,
All
we
right,
will
sounds
see you
good.
Monday. Take care from Tea Talks.
Bye bye.